Well, good morning, everybody. My name's Jeremy Cooper. I was asked by Paul to present a lecture to you today, and it's in two parts. The second part particularly, I suppose, there's a lot of new techniques and keep the best till last, they say. If you've got any questions, then by all means, put them on the Q&A section of the presentation, and just I'll try and work through those at the end. I won't interrupt myself until the end to answer those, and I hope I can answer them. I will realise we've got a wide audience here, and I know it's troubling times, difficult times with the COVID-19 epidemic or pandemic, and it's quite surreal lecturing when there isn't actual interaction with an audience. I think I will now begin. And so, why am I here? What gives me the right to address you all? Well, I published a number of articles on MID, and it wasn't really with any intention that I actually started out by publishing MID. I suppose it was a philosophy that I adopted over many years. And I started actually writing articles, and it goes back really. I qualified a good number of years ago. And between my qualification, which was, I should say it not too loudly, 1982, I published a few articles on everything from postgraduate dentistry to, I was the first dentist to use thermofill, which now is gutter core, and I've written on many different subjects. And I think back actually to about 1992, when I wrote an article in the British Dental Journal, and it was called "The Cost of Keeping One's Hands Clean." And it seems quite relevant today because of COVID-19. And I remember dentistry, and maybe a few of you watching this presentation will remember the days of not wearing gloves. And I won't get too graphic, but just to say that it was quite an experience of having clotted blood on your hand and then just opening your hand and feeling it crack. And I'm pleased to say that not many of you will have had that experience of feeling that. But dentistry was different. But HIV changed everything, and we suddenly all started wearing gloves. And I dare say with COVID-19, we'll also adopt new protocols. However, what I do want to say is that back in 1992, I wrote this article, and it was a follow-up to some workers from Liverpool University who suggested a regime, and I kid you not, for washing gloves. And they described all the protocols and everything else. And I suppose the Liverpool-Manchester rivalry, if you like, existed even in those days, because I really shot it out of the water, and I did a time and motion study, and it was reported in the PDJ and written up as a refereed article. And I just said it just didn't make sense from a time and motion and how long it took you to do the procedure for the cost of gloves. And in those days, we had gloves which were right and left, and they were in beautiful packets called Biogel Ds. And even then, they were over £1 a pair. And I just say it just didn't make sense. And you might as well just throw your gloves away and use a new pair, regardless of the fact of whether you could actually clean them or not. And I think, why mention it now? Because time is something very precious, and often people are looking at the cost of materials and the cost of doing something, when really we should be focusing on the time. over from about 1992 really till 2012, I wrote a few articles. I'd written before this one in 2012 on whistleblowing, something I feel very strongly about. But I've written on a few things, but I suppose times of being on committees, involved in postgraduate education during that time as I was. But I started writing again, particularly from about 2012. And the acute aesthetic dental emergency. And I didn't realize actually at the time of writing that article, and I was asked to write that by Linda Greenwall, and who is the editor for Aesthetic Dentistry today. And this lady attended frantic. And you can see why, because her upper canine made her look a bit Dracula-like, and it had been done very sloppily, and it did not look good. And it had almost, I don't know, been put on with a huge overhang on the palatal aspect, and it really wasn't done well. And she was really, really concerned. And to me, that is an acute emergency if it's really affecting somebody. And I think sometimes, particularly at this time where we really are only seeing pain and people can have front teeth, crowns being lost, and you're not an acute emergency. But in normal times, that is an acute emergency. And I literally just flicked it off and just restored her appearance. And I have this phrase which I often talk about, and I say, a patient in trouble will cause you strife, but a patient out of trouble is your friend for life. And I think that's really pertinent. And if you help somebody in, difficult times, they don't forget it. So moving on, I carried on writing on, as I say, whistleblowing. My first venture into the world of layering of composites was with Aura, an SDI product. And I went to learn about it. I took part in the clinical trials of that material. And we'll discuss layering of composites probably in part 2. That's where the real meat on the bone will be. That's hopefully you'll join me again. We'll discuss ICON. And I've written, I suppose it's pertinent, with Paul, as many as you know, was a ex-professional cricketer for Lancashire. And being in Manchester as well, and I used to go to watch cricket. Who knows, I might have even watched Paul many years ago. He's a few years older than I am, not many. But I talked about childhood caries and fluoride, and we'll talk about that. We'll talk about veneers, but we'll talk about that in the second part. But I like to call myself, and going back to the cricket theme, is an all-rounder. So I've written on many different topics, clinical and non-clinical. Aerobrasion obviously is a topic which is heavily involved with MID, and I've written an article actually on MID itself as regards cosmetic dentistry. More on the veneer and complaints, and that's also something I really feel strongly about, of how you deal with complaints. And people are certainly now in this new world we live in of litigation, and our regulator, the GDC, being, making life difficult, shall we say, for many people today. Fibre posts, I'll even refer to those today, and we are talking MID, but that's really at the other end. And evidence-based dentistry we'll refer to during the presentation, as we will, about aesthetics, and looking at it really from the side of the dentist as well as the patient. I think we should never forget that. So this is pertinent when I tell people, particularly from an international audience where I'm from Manchester, and we'll see a picture here. Many who live in Manchester will recognise that as Deansgate. And I used to joke with people saying that this was taken when the Starship Enterprise phased away all the cars and beamed everybody aboard. Alas, and that was taken actually on Christmas Day a good number of years ago, but probably about half a dozen years ago, I should think, something like that. But today, I'm sure we could see Deansgate many times looking like that since the COVID-19 pandemic. I was dentally born at the London Hospital in Whitechapel, and famous probably for its most famous patient, Joseph Merrick, who many of you will say who, portrayed by John Hurt as the Elephant Man. And I used to study opposite his bones and a model he had made in the Medical Museum on many an evening. My passions, fast cars, but always Jaguar, unlike Paul, who likes his Porsches. Manchester United, I can hear the hissing now. And I have a love for Scotch malt whiskey. I have a suburban practice. And I think I'm pretty, I won't say unique, but pretty unique, probably, on the lecture circuit. I still have NHS patients like many of you have, and that's through choice, okay? More of my income, I will quite openly say, comes from the private sector. But through these troubled times, hasn't it been turned on its head, with now the strictly NHS practitioner being the one who's perhaps on sounder ground at the moment? Times are difficult. These people matter to me a lot. This was taken on one of our staffed Christmas trips a couple of years ago. We went to County Mayo and Ireland, and they're an important part of my life, and we Zoom regularly even now during these difficult and troubled times. So moving on to the lecture today, we're going to talk about concepts of cosmetic and MID and restoring teeth quickly. And I really go back. Time is so important to me. I can't charge sometimes the fees that say they will in the more affluent parts of the country, being in Salford. I'm in a sea of caries in Salford, and I have a completely mixed crowd of people. People are very affluent to people struggling on income support. We'll talk about case assessment, treatment planning, and shade selection as we go through the presentation. Economics and financial viability, particularly in part 2, but even during the presentation I'll refer to that. And we'll talk about layering of composites and finishing a number of times during the presentation. Clinically, we'll move through many of these topics, and we'll talk about them. If you're expecting a lecture of pure science, I'm not your man. I'll leave others. Sorry, I'll just go back one side. I'll leave others to actually discuss the science. And if you want lots of electron microscopy, I certainly am not the person to get into that. And I'm sure you've attended many lectures and had your matchsticks trying to keep your eyes open and your mind wandering. Well, I think giving webinars is difficult enough as it is to keep watching and to keep people entertained. But I often switch off when I see huge amounts of data on a screen. So with no more ado, I'll go back to that slide, and I want just to give you a few seconds to read what MID is. And having read that description of it, I'd just like to say, although we're going to be talking restorative aesthetic at the moment, actually, it involves all parts of dentistry, and we should never forget that. Orthodontics, what's that got to really do with MID? Well, if you arrange the teeth in a nice arch where it's easier to clean, you may intercept periodontal teeth, make it, and hopefully stop it from reoccurring and improving the health of the periodontal tissues. So that can happen. Periodontal therapy, it's, we're not cutting away lots of tissues a lot of the time, unless we're doing radical periodontal surgery. It may be little or no tissue cutting away, but we're improving periodontal health. So yeah, it follows MID principles. So just never forget that. But obviously today I'm talking more, and certainly next time we'll be talking much more on this theme. And I, at this point, want to say that we have indexes, don't we, for just about everything in dentistry. We have indices certainly around periodontics, and are they not ever changing? And even the names going from debris to plaque to biofilm or whatever. We have indices for orthodontics, indices for wear, indices associated with the bone quality in implantology. And when I wrote my article a few years ago on MID, I thought it was important to look at treatment overall. And I came up with a cosmetic, I called it a cosmetic treatment index, but it's really a treatment index. And I think you'll see why as I go through it. And I called level 2, treatments involving no restorative material being applied to a tooth. And you'll look through that list and you'll say, bleaching? Well, you could argue about psychology being improved, but think laterally. And I do think laterally a lot in my dentistry. Bleaching, you know, the effect of the breakdown of carbamide peroxide or the hydrogen peroxide into oxygen means that the tissue gingival health will improve. And therefore, yeah, it will be following MID principles and improving the periodontal health. Fluoride's obvious. I'm not going to teach you to suck eggs. Recaldent is a constituent of GC's tooth mousse, and it's amorphous calcium phosphate and casein phosphopeptide, which is derived from milk. And these things encourage remineralization. Enamelon's another product by Premier Dental, American company, and that also contains amorphous calcium phosphate. These are just examples, and will encourage tooth remineralization. Voco's Remin Pro has different constituents. It's got fluoride in, hydroxyapatite. It's put in as hydroxyl apatite, and I'll be honest with you, I'm not the scientist. I wonder why they call it hydroxyl as I always call it hydroxyapatite. But it meant to fill in little cavities in the tooth and repair the tissue. Does it? I don't know. I just listen to what the scientists say, and xylitol being bacteriostatic. Icon we're going to discuss later, but it does have like a sealant involved with it. So is it a restorative? I think it's minutiae, and I'm not going to even go down that, but it doesn't actually involve a restorative material. When we go on to level 1, we're thinking about restorative materials that can be applied to teeth, and you just etch and bond. And you look down that list and you think, well, obviously abrasion, erosion, abfraction. You can talk about attrition. I always remember great fondness about abfraction. One of the first people to discuss that was a guy called Ron Jordan, and I heard him lecture in Manchester. It's long dead now, a good number of years, from Canada, and he introduced that concept of, you know, when clenching, grinding, little bits of tooth tissue breaking off at the neck of the teeth and producing these wear concavities. And I always think, why did nobody talk about that for so many years? And did they really believe it was due to acid erosion or toothbrushing? But Ron Jordan really hit the nail on the head. And I think certainly an occlusal expert like Paul will often discuss these things a lot better than I can, but it's certainly a part of my everyday dentistry in repairing teeth, certainly minimally invasive as well. Veneers, and I mentioned things like lumineers, and, you know, I'm a great advocate of somebody I respect, was one of my teachers while at dental school. He was a registrar there, now a very esteemed professor, and Martin Kelleher. And he talks about porcelain pornography and the daughter test, about would you do that on your own daughter? And yeah, I further extended that concept to the self-test or the mother test. Would you do it on your mother? And a lot of what we do in dentistry and techniques, and people will argue, oh, but I'm improving the psychology of the patient. But how many people really stress, you know, that when you do a veneer, how long is it going to last? 5 years, 10 years? Averages really do vary. And when you do things to teeth, how easy is it to replace them minimally invasively? And I think sometimes we produce these restorations in materials sometimes incredibly difficult to take off, like zirconia. And even with burrs that are made specifically by companies like Comet, how difficult those materials are to remove. But remove them we will. You know, nothing lasts forever. And even when it's well done, there are many reasons. They become chipped. They become, you know, margins showing where the patients are insisting to having them replaced. And I think we really have to think with a minimally invasive cap on. Doll inlays, onlays really are incredible. And, you know, they have revolutionized my dentistry. And I'm sure many other people, and by adding pieces of composite to the surface, think MID, of course, you're going to help Paul's TMJs and move the condyles back by increasing the OVD and prevent further wear and help the TMJ. So you've got to look at MID from many different aspects. Moving on to level 2. This is where you may be taking a tiny bit of tooth and, you know, particularly things like air abrasion I will refer to, but you may want to just remove some unsupported enamel before you restore a teeth, or veneers where you're actually doing tooth prep. And I'll talk a little bit about that. I don't have too many worries about tooth prepping with veneers, and I don't think it really matters a great deal. We move on to 3, and this I call your bread and butter dentistry, your fillings, your inlays, your onlays. And just to separate out with perhaps more advanced restorations with partial full coverage restorations with slots, pins, cores, and so on. And just to finish off, 5, if we're looking at treatment, you know, replacing missing teeth and prosthetics. And I think the overriding reason for going through this is really to say that 0, 1, and 2 are your MID. And that's really, if you like, where we should be headed. And I think too much of the time, we're almost going in the other direction in thinking through inlays, onlays. And 3 and 4, therefore, is conventional. 5 is your prosthetics. And I think that's it. That's the line. We should do as little as possible. But we've got to take that with a pinch of salt, because sometimes doing too little, I will admit, may not be the right thing. You may want to realize that there are times where, yes, you want to do something more extensive. So at this point, I want to take you back, and I hope to make this lecture a bit entertaining, but I want to take you back to a story that happened to me. I was aged about 5 years of age, and my mother and my father fortunately got divorced. And what happened was that my mother, being an American citizen, we went to live in the United States. And I've given this lecture before, and I used to say this and not think twice, but believe it or not, the place where I went to live from the mid-60s was a place called Corona. How, you know, weird that I should be mentioning this today, which is in Riverside County in California. And we went to live with my gramps and grandmother. And after about a year, my mother met somebody else. And he was a businessman, a very affluent businessman. And I lived in an incredible house. We had the house in Newport Beach. At the age of 13, I could navigate, I could play around, drive a motorboat. By the age of 16, as you can there, I was learning to drive. And I actually learned to fly at the same time. I was pretty good academically at school. High school was fine. I had no interest in going on for further education at that time. I was interested in one thing, and I was interested in the Corps. And for those who don't know what the Corps is, it was basically playing at soldiers. And I absolutely had a love of it. But I was a rich American brat in those days, with still a bit of an English accent. It's amazing how that didn't change that much, but I did used to have a little more of an American twang, but that went. And when I came back to the United Kingdom, but in those days, I just was interested in firing guns. And because the brat element, my Stepfather had been a US Marine, Korea. I was not interested because he had been in the US Marines, and being on the coast of America, I joined the US Navy. And very quickly they knew I fly, and I became a US Navy aviator. And I enjoyed it. And I'll never forget being on leave. And you know how it is in those days, didn't have one of these. I was on leave, cocky, yeah, pick up the phone, it rang. And it was immediately, I like almost jumped to attention. It was my CO. And he said, Cooper, you're not to return. Not to return. And it's like getting a letter from the GDC or your regulator. I thought, OMG, I was always in scrapes. I was an arrogant, little cocky little so-and-so. I was always in trouble. And I thought, this is it. I'm going to be court-martialed. And I was thinking of all the scrapes I'd been in. He says, you're not to return. And I'm thinking everything going through my head. And then the next minute, you go from down there, and immediately I'm up there, because he says you to report to Miramar, a place near San Diego. Some may have. And the whole point, you see, you dentists, you know, are conditioned, okay? And it's a Dalek, and I was conditioned. There I was, you know. I thought I was in trouble, but hey ho, I wasn't in. I'm now going to the place of my dreams, because you know where I was going? I was off here. And I was going to Top Gun. Now that film's a lot of nonsense, but they did teach you to be the best of the best. A picture of me looking a bit more handsome, my full flight gear, and in front of my F-14 Tomcat. And they did teach you to the best of the best. And there I was, a pilot, and I really was conditioned. I really thought I'm one of those, you know, top guys. I was, you know, immediately thinking, there I was in trouble, and the next minute I'm elated. I am. And I'll return to about conditioning in a second. But they taught you to the best of the best, and I couldn't believe it, how I thought I was good, but I met people who were better than me. And I think that's like that in dentistry. So immediately after being trained from Top Gun, I went back to my carrier, and I had to fly all the way to Japan and then by helicopter back onto the carrier. And I was on that carrier, and within a very short period of time, something came up on the radars back a couple of days, and being a first responder, I was scrambled. And before I knew it, I was up in the air with a flight of 3 of us. It's 3 planes. And yeah, there were about 4 or 5 Russian MiGs. And we call this the flip. And there you can see from the film, and there's Tom Cruise at the front giving the finger to the MiG pilot. You could never get this close. Your cockpits will be smashed together as opposed to pulling apart. And there's his co-pilot Goose taking a photograph, and with a Polaroid. Now I've got to tell you, this incident did happen. It wasn't a Polaroid. It was actually one of those little Instamatic cameras. And how do I know? I've seen the photograph. And more to the point, I was flying that plane. And here's a picture of me on the USS Midway with my Top Gun hat. The ship's in dry dock, and everything I've told you for the last few minutes is absolute garbage, trash, as the Americans would say. My mother was English, unfortunately not with me anymore. And I was schooled here, and I never went to the United States. And why have I wasted a few minutes of my presentation? And I'll tell you what, just to prove about conditioning, how you listen and do you think back to the time you went into university. You listen to your lectures, you get your books, you read, whatever they tell you, you take in. And now I agree with social media and fake news, it's ever more important. And then you qualify and you come and listen to people like me, and I'll tell you about the megapascal strength of this or that. And you take it all in and you listen to your reps in your companies and your journals, and you take it all in, and you'll hear the prof this and prof that telling you this, and then you'll listen to another prof telling you something different. And you're just conditioned to just take it in. And we all do it. We don't necessarily question all that we should. And that is one message. Please don't. And I know I've gone on about this, and we're at times here. I want to really alter your perspective. So when you actually look at the surface of the moon, if you like, and just remember it might not be, and that was taken on us at the ADA convention just outside. So I really want to get that. And is it applicable today? Yeah, it's really applicable. It's applicable when we're talking about MID. It's applicable when we're talking about research. So hopefully, this is one message that you'll take in today. So why have I talked? Because of this, and I've just alluded to it, evidence-based research. And let's talk a bit about MID fluoride. And to be fair, when fluoride dentifrices toothpaste came on, they never expected it to have the effect it did. They really didn't think it would affect 30% by reducing caries, maybe more. And I saw a journal, it was evidence-based EBD, evidence-based dentistry, part of the BDJ, and it was discussing fluoride, and it was discussing topical fluorides, and it was questioning how effective they were, the gels particularly. And there was huge disparity with how effective these things are. And at the end of the article, I can remember it, reading it, and it said, we should be using fluoride varnishes. And you're all, particularly if you're in NHS practice, encouraged to put these on 3 times a day. I know I am. And they actually ask for the figures, don't they, from the NHS? How much are you putting on? And they publish figures to tell you how much of this fluoride varnish you're putting on. And what's interesting, research was done a few miles down the road from where I practice, and it says 43% to reduce dental caries. And I thought, that's really interesting, since I'm about 5 or 6 miles from Manchester Dental Hospital, which is Salford to Manchester. I don't get 43% reduction since I've been plastering on these fluoride varnishes. So do you think that the research is bent? No, I don't. Well, how can it not be bent if you're saying you don't get 43%? I actually look at it and think of it laterally, and this is what I encourage people to do. And I've even spoke to the head of scientific people at Colgate, and I've said, look, we know that fluoride goes in, it forms fluoroapatite, but equally the ions come out. It's a dynamic thing. So think logically, how can putting a fluoride varnish, which may be a bit sticky and lasts for a few hours longer, and in a higher concentration, go into the enamel surface, and then it comes out, by plastering it on just 3 times a year or so, reduce caries by 43%. What's going on? And I thought about it logically, and you think, little Johnny goes into Manchester Dental Hospital, open your mouth, thanks for little Johnny, goodbye. And then Mary comes in, Mum, would you like Mary to take part? Something very safe, it's fluoride, we're using it in our toothpaste every day, but this will give her extra protection. And by the way, here's some fluoride toothpaste. Can I just encourage you, don't use water to do it. Spit out, don't rinse, and reduce the number of times you're having sugary foods and sugar-free drinks and so on while they're doing the topical fluoride procedure. And then, hey ho, you might get 43% reduction in dental caries. So it's just actually looking at information and actually assessing it and realizing it. But I think it's a myth to say that it actually, purely putting on a fluoride varnish onto a tooth surface reduces caries by 43%. That is genuinely my own thoughts. And I have no, dare I say it, evidence base. And so I always take evidence-based research with a pinch of salt. And then I'll come across somebody like, and I mentioned this, Gordon Christensen. Now, some of you will say, who's he? He influenced my dentistry more than anybody has done over the last 30, 40 years. And he is American. He has his own research institute, teaching institute in Utah. And Gordon, if you ever get a chance to listen, and I say this, really meaning this, I don't think there's anybody who has a better all-round knowledge of dentistry, full stop, on the globe. And Professor Gordon Christensen is a wet-fingered dentist. He's in the real world. He walks the walk, talks the talk. I've seen him do literally amalgams to composites. His knowledge is phenomenal. His research institute will not be bought by any manufacturer. They send materials to him. He sends them out to dentists for assessing, and they test them in the lab. And they produce something every month or so called Clinician's Report. It used to be CRA, Clinical Research Associate. And for decades, they've been producing information. And this edition, it will tell you about curing lights, and they will ask, and I listen to that because it's unbiased research, and it's many thousands of dentists who have put their two penneth into it. And when I listen to a lecture given by Gordon, assessing all the different composites and all the curing lights or whatever, you know, you can say it's pretty comprehensive, and I listen to what he has to say. But this is something else that gets me, as I'm sure even over COVID-19, we're looking at research at the moment. And we'll see size of studies, and we'll look at Cochrane reports, and we'll look at meta-analysis studies. And when we look at these meta-analysis studies, hey ho, you look at them and you think, yeah, it's a meta-analysis study. It's so many different research. It must be true. And even when I did the article, I'll refer to it now on Fiber Post, I went to meta-analysis studies. And even the authors of some of these reports said, we actually don't believe what we're reading, because, for example, with Post, they were saying that fiber posts and metal posts produce the same rate of failure in the roots and root fractures, which we all know on the, if you like, on the front line, it's just nonsense. You know, sure, ferrules and things are all very important, but if fiber posts fracture, they often don't fracture the root. They can, but a lot of the time they'll fracture at the where the post goes into the hole. And metal posts, sure, you'll get a higher incidence of fractured roots with these things, or that they fall out. So don't always even, you know, question everything you read. And I always gets me really wound up when I see two different studies and almost identical, but coming out with different results. So just always look at reports and just take them with a pinch of salt. And time, there you go. How many times do we see, you know, evidence-based research, and there was something, oh, it was researched, and there it was on the market, the American dental laser. I saw it back in 1990. It was released at the New York Dental Show, and it was like, come and play with this, cutting up bits of meat and taking away caries. And you took away this caries, and you like spoon it away, and it would come off, and you think, wow, the aerator's dead. No, it wasn't. And even when they introduced erbium YAG lasers, which would cut away the enamel, it still wasn't the end of the story. These things were too slow. And lasers, great for soft tissue, but really not for hard tissue to a major extent, certainly not at the moment. And then that product, Soft Scale, I think it was Dentsply that brought it out. Put it on some calculus, and then 2 seconds later, or a few minutes later, you could take it away and it would come away like butter. Great product, just didn't work. So that's my cynical approach, and just always wait. And I know new technologies are coming out all the, you know, when should I buy this? When should I buy that? And, you know, I am one of those now. I used to jump in, but actually I wait a little while for the technology to take hold. Sometimes a little too long, I must admit. So there's Prof. Gordon Christensen, 80 years old, still riding motorbikes, teaching, practicing to this very day. So let's go on to isolation. And as I said to you, don't worry, you're going to get a lot more about MID particularly over the next lecture as well as today. We're on to rubber dam, the gold standard, no argument about it. But even that, we'll talk about evidence days. How many times do you put a rubber dam on? And you put it on, as we all should be doing now, for endo. And you put it on your molars, and I must admit, most of my MO and DO boxes do finish at or below the gingival margin. And how irritating I find it when I'm doing my endo every so often, the nurse will have to go with a little fine sucker to get the leakage around the box. It's irritating, isn't it? But then, as soon as I'm doing my restoration, I've got rubber dam on. Doesn't leak, does it? You go to all the lectures, put your rubber dam on. Doesn't leak. And you're thinking, what about floss ties? Where did they come out? I mean, I've been practicing dentistry a long time. It may be the last few years that floss ties come. Oh, I'm using a floss tie. I'm pulling on the floss. It's going down. It's being pulled down. It's great, isn't it? Where's the evidence base for it? In fact, there isn't that much evidence on rubber dam actually making your restorations last longer. Don't get me wrong. I use rubber dam a lot, but I don't think it doesn't leak, because it does. You can mitigate it, and I'm not saying that it doesn't reduce contamination, but it doesn't eliminate it. And too often you go to lectures and you see people do fancy work and using rubber dam. I do not use it all the time. Sometimes it gets in the way. How often do I find it get, sometimes when I'm doing it, gets stuck between my matrix and a tooth, or I find it just getting in the way. And the split dam technique I do use quite a bit, and it's a great technique, and I'm sure lots of you are using it. And here's a real life patient. Don't you love it when I see there's a little bit of plaque on a patient, and the patient is a heavy smoker, but he didn't like the spacing. He wasn't bothered. I'm never going to get him to really get optimal oral hygiene or anything else. I can encourage him. He can see my hygienist. She can instruct him. We can try and motivate. But this guy just wants a little bit of cosmetic. I'm not going to crown those teeth. So in this particular case, we just get a rubber dam. You cut 2 holes in it, cut it, not even straight in this fashion, doesn't matter. And, you know, with a wedget and a dam, put it on so that when I do get my air abrasion, I can do it. It reduces contamination, doesn't eliminate it, but that rubber dam isn't getting in my way, makes life easier. I'm quite happy. And Roger was happy as well, as we just eliminated those spaces for him. So I use split dam. Liquid rubber dam is something I found that many dentists really have little knowledge about, but it's a useful thing. And QED sell it, Circumed, and Voco do one, LC dam. And I often will use liquid dam. And there's a molar I wanted to, it's a bit sensitive, it's a bit stained there. There's the 2 liquid dams. And you just, there's a Circumed kit, but maybe. And there you go. And you just syringe it around. It's not acid etch, that. You just syringe it around the gingival margin, and just, there you go, close up of it. And just like cure it. And that's all you do. And then you can air abrade to your heart's content, and you're not going to abrade the tissues and therefore get them to bleed. And that's something when using sometimes with rubber dam that you can actually, particularly if the gingiva is a bit inflamed, it wasn't bleeding before, but after you've tried to pull on it with your floss ties and try and pack it in the margin, it can actually cause bleeding. And sometimes, you know, people who use cord will report, oh yes, that's it. And then you're putting all your chemicals on to trying to stop the bleeding from your gingival margin, because many of my patients do not have perfect oral hygiene. So thereafter, I've taken it off, and I can restore the tooth and just show you there's no bleeding gingiva. So liquid rubber dam, but I'm not worried about using cotton wool rolls, dry guards, near dries, and near dries or something you can Google whether, I used to use a company called Dental Express for those, but can't find them. And they're absorbent on one side and they have this metallic surface on the other side, which is great because it will reflect your curing light. And you just put those in the sulcus, and a useful thing to have, you know, up your sleeve. My staff has said very important. So I recently had my 60th and they took me all the way to, I didn't know where I was going. It was the magical mystery tour and they took me to the Cavern Club and I stayed in student accommodation and they just took me away. It was amazing. But let's talk about Icon. Icon is one of those, I call it like penicillin of dentistry, that it was really introduced to put on brown, white spot lesions, to basically etch into an early carious lesion, and then you would seal it up. But they did find that white spots kind of lessened when they put it on. And so we talk on to minimally invasive dentistry, and it's good in aesthetics. And what I will say to you with the use of Icon is that they've tried to make it much more of a science today, haven't they? And they've tried to get you to do differential diagnosis of what's causing it. I think it's very difficult to actually do a differential diagnosis on occasion of what's causing the white spot. And you can ask your questions and you may get some answers, but a lot of the time you don't know. And what's really important is how thick, how is it really restricted to the surface, or does it go really deep into the tissue or right through the enamel? And therefore, sometimes I'm afraid it is suck it and see. And you've got to build that into your fee structure and be under no illusion, as I'm going to show you in a second, how long Icon takes to work. And yeah, it's non-invasive, so I love it. And when it works, it's fantastic. And just look what you've got to do. Here I am, rubber dam, absolutely mandatory. And I would say at this point, try using liquid dam under rubber dam to get the best seal. Whether you're doing restorative, it's difficult, very difficult to do well. But actually, it will reduce that contamination to minimal. I don't say eliminate it. You've heard what I've said about that, but it will reduce it even further. Why you've got to use it? Because we're not dealing with orthophosphoric acid here. We're dealing with probably the second most dangerous acid we use in dentistry. I would put hydrofluoric acid with porcelain etching as number one, but hydrochloric acid, this is dangerous stuff. And look how long you're going to be etching with it, 2 minutes. And the technique takes forever. And as dentists, we like to be doing things, and waiting for 2 minutes is a difficult thing. And then you aspirate and wash it for 30 seconds. And after you've done that, you'll dry it. And then you'll put on Icon dry and then dry it again. And you'll look and you see that's 30 seconds. So look at the time. And then you'll look at it and say, yeah, it doesn't look that good, so I'll do it again. And you repeat it 2 to 4 times, they say. I've done it 5 or 6 times. And you've got to build this into your model. Never mind the price of the kit, which is not cheap. You've got to think, what happens if I don't get ideal results? Always be thinking, so build it into your costing. And then even when you think, yeah, I'm there at the end, 3 minutes, you can die waiting for this. And then you cure it for 40 seconds and do it again. So look at a clinical case. And we put Icon on. And we rub it in with the applicator. There you go. You rub it on. And you rub it on. And then you wash and you dry it. You put on your Icon dry and you look at it. And you do it again and again. And then when you're ready, you put on your infiltrant. And that isn't a floss tie, it was just floss to get it down beyond the contact. And that was it. Needless to say, that patient came back and I had to aerobrade it away. And perform a conventional restorative measure, free of charge. Here's another patient. This child was getting bullied. Mum was from a socioeconomic route at the bottom. And what did I have to do here? I had to give some reassurance to Mum, and I did it, and I said, you know, we'll see how it goes. And it was a couple of £100, I think I charged Mum. And that was the result. And it meant the child could go back to school without being bullied. Became a thing of the past, and somewhere I've got a follow-up where, you know, his oral hygiene was never good. Required some scaling or whatever, but he wasn't interested until I've got his motivation there. And then it did get better. Taking staff that year, we went into Holy Land, and we went through cloak and dagger stuff, and we went into the Palestinian territories and went to Bethlehem, and I took them to the Church of the Nativity, as well as in Jerusalem to the Church of the Holy Sepulchre, and through a minefield to where Jesus was baptized in the River Jordan. They matter to me, as I say, an awful lot. So here we are, simple case. This is Anne, age 70 odd, an MOD amalgam that I did. And this is taken a few years ago. And I did the crown as well. And I want you to look at whole patient care here. There's a view from the buccal aspect. Okay, think about her age. There's a radiograph. What's your treatment? What would your treatment be? Let's go back. There it is. There it is. So you've seen. Well, let's think what you could do. Was it cutting her tongue? No. Was it hurting her? No. So you could do nothing. You could go to level 0 and put some fluoride varnish or one of these topical fluorides. You could say, well, you haven't had enough time. Perhaps it will get carious. It's not really a good idea to restore it. She's age 70. If you haven't, I can tell you, had a high caries rate. So that's realistic. One, you might say, well, there are some sharp edges perhaps on the lingual surface. I'll take those away. Level 1, if you like. Or 2, sorry, and just restore that. Or you could just literally, without doing any tooth removal or anything, and just put on a composite, that would be level 1. But as I say, you could get sharp edges or aerobraid as well, level 2, then restore it. Level 3, you could take away the rest of that amalgam, put a composite in. Could even do an inlay on onlay. Perhaps an inlay if you really wanted to. 3/4 crown, do some accessory retention, level 4. Perhaps build a core and do a full coverage crown, also level 4. I don't think you're taking it out. So what do you do? And I think that is, what's the right answer? Would you take away that calculus there? Come on, she's 70. If that's the amount of bone she's got, I don't think it matters fig whether you take away that calculus or not. We probably as dentists conditioned, we've got to remove calculus. So what would you do? So yeah, I decided we'll take the amalgam away and we'll restore it. And I used an Omnimatrix from Ultradent there. And I cured it and put my composite in and restored that tooth. And finished it. Finished. And we used Grandioso 3.25. I'll talk about that in a little while. As I come. So bonding. Before I talk about restorative, I just want to talk about bonding. And this is where I said, you're not going to get your micrographs. These are the questions I literally ask myself when doing this. Do you need to etch? Are you using a bonding system? Do you prime and bond? Do you use separate bottles? Do you light cure? Do you dual cure? Do you know if your bond is light or dual cure? Is your bond silinated? Do you care? And how long does it take to do? time again. Time is money. And it may surprise you to know there's no one bond that does everything, not one that's on the market. In fact, they will pour scorn at each other. And you know, a lot of them will say, for example, you can't use a silane and get down to the pHs you need to do. And if you clear fill, that has a silane in as 3M Universal. Futurabond U and the others, Optibond, this one, don't. The literature is incredibly confusing. You'll attend lectures about bonding and you will listen to great people, Trevor Burke, John Canker III, and you'll come up and listen to what they have to say. And you know what, that was a great article. It's still relevant today because very little's changed in bonding in recent years. But that article, American company Bisco, The Evolution Continues, put that into Google, you'll get an article. And it gives you a good overview of bonding and where we are still today. I don't have one bond, I have two. I use Futurabond U by Voco and I use 3M Universal. And the question is, do I actually understand the science? No. I'm going to tell a lot of people who are giving the lectures, professors included, do not even understand to the degree they really need to understand the actual dental materials, the actual chemistry, because very few are scientists as well as dentists. John Canker is an exception, and he's done the research in the laboratory and knows the chemistry and even come up with his own bond. He used to work with Bisco and he now does his own bond. And Futurabond U, very similar, simple to what you're using. And I think a lot of you will be using 3M Universal. So you just, press it, same kind of thing with 3M Universal, mix it together, pierce that metal with a little applicator. And after you've etched, and just mention, it's worth mentioning that you go to Trevor Burke, he'll tell you to selectively etch. John Canker says, load of nonsense, you can't selectively etch, therefore total etch. It's a load of nonsense, you can't do it. I think everybody's agreed that you get higher bond strength if you just use etch as well, and that with these primers that are involved, they'll get you down to pH 2, so they say, but you really need to get down to 1 with an acid etch with your orthophosphoric acid. And you just squeeze them, mix them, and you apply them to the tooth and rubbing it in and agitating it for 20 seconds, and then you'll blow it dry for a few seconds, and then you'll cure it. And it takes the same time whether you're using this, 3M Universals, and a lot of the other ones too. What's interesting is that even the scientists at 3M sometimes make mistakes. And I spoke to the head of science, this is absolute truth. And I was at one of the big, annual conventions, and I said, can you explain something to me? I said, I remember my physics from A level. And I said, I remember that light goes in straight lines. So I said, well, I love Ultimate. That's one of my favorite materials for bonding into roots with fiber posts and luting it. I said, can you explain to me how the light I put over the post hole, if light goes straight, it may do the first couple of millimeters or so of the dentine at the root surface, but how's it going right down the root? He looked at me horrified. And he really had no answer for a few seconds. And he says, yeah, the Ultimate will cause it to start setting. And I said, nonsense. I said, you just thought of that. And I genuinely say that. That's why I have two bonds. Futurabond U, dual cure. So when I'm using that, I know that blowing it dry, not curing it, waiting a wee while, that will self-cure. Now you'll say to me that 3M Universal, if you really left it a long time, it may self-cure, and it may do over a period of time. But I prefer to use a bond that is actually dual cure for cementing a post. I won't necessarily do that for when I'm doing porcelain and things, and then I'll use a ceramic primer, belt and braces approach, and then I'll use 3M Universal, which has a silane in, which everybody else says doesn't work, but 3M say, yes, it will work. And so will Clearfill. So who do you believe? And the answer is, I really don't know. A little bit about composites, and then we'll move into the real meat of my presentation on visit 2. This is really our bread and butter of minimally invasive dentistry when using composite or other materials now, the ormuses, the organically modified resin ceramics. Really, the difference is that we know that the Grandioso, which is Voco, is the first nano, one of the first nano hybrids. And, you know, people talk about these things. They're just little glass particles in a matrix of dimethacrylate, which is your resins. And really, the resins are just replaced by a ceramic resin, if you like, not a resin in the conventional state. And that's what these ormuses, such as Abmafusion, are. And they're great materials. How much better are they than your conventional Grandioso? Time will tell, but I'm not sure. I still use this material a lot. And it's a nano size, just means small, and it's 87% filled. And as a rule of thumb, the more filled a material, the more it will wear. And we're going to finish the presentation in a minute, and don't worry about that. And you use your usual shades. And I love this material because it has opaque shades as well, which you don't get with many systems. So it's got opaque ones. And then it has what I call my in-between shades. It'll have 3.25 going before 3 and 3.5, A3 and A3.5. And it's got one darker than A4. So I do like it. And it's got really light ones in bleaching shades. And I was for donkey's years, I just was a 3M man from the very first. And I still think they're great materials, and I will use them on occasion too. Little bit about matrices, just as I say, before I finish the presentation, Pro Matrix. Made in Manchester, or the company that distributes them, part of Young now, called Aztec Innovations. And I love them because they're not blister packed like the Omnimatrix, and when you tighten, they don't fall apart. And I like them also because of these, and I took part in the clinical research for these. And you know, when you're using the matrices, one of the things about matrix bands, people say poo-poo them, is that they say, yeah, because they don't produce the natural convexity of the Garrison system or the B3 systems and all the rest of it from up to down. But these are actually curved. So when you put them on, and there I am, hey presto, I was using a rubber dam there, and they're actually curved, so you get great contact points. And I urge everyone, try these. They're great, and you don't get that bit of composite coming round your mesial distal, particularly with wide boxes, that you do with a little matrices system when you wedge those. And I really do rate these products, but try them yourselves, and what works for you is. So there I am. I've gone a little bit over time, and I'm going to have a look at your questions now. And that actually is of Sydney, literally a couple of weeks ago. And I say to this now, I'm sitting here. I was a plane away, I reckon, from being stranded in Australia, having come off a cruise ship full of COVID, as it proved to be. And I'm thankful I'm sat with you and COVID free as far as I know at the moment. But you thank your lucky stars, and that was the exact colour, nice orange glow of protective glasses colour. So keep all protected. I'm just going to now have a look at some of the questions that have come and see if I can actually look at those. So I will see if I can click on the Q&A. I think I've got to stop sharing at this point so that I can have a look at the questions. And I'm having a little bit. So here's one of the questions. What was getting the matrix that you just mentioned, and where are you getting from? Henry Schein. They are called by Aztec Innovations. And I think Dental Directory probably sell them. I'm not sure, but you'd have to check, but certainly Shine do. And you want there's two, and I use the two in different situations. The curve is the one which has a curved contour, so you can get great contact. And they do a straight one which are the blue and the green. And the difference between the different colors is the blue and green. One is the wider matrix, one's the narrow matrix for premolars and children's teeth. And similarly, the orange is the wider one and the yellow one's the narrower one for the curved one. And I find there's, you know, it's certain occasions I will use the straight ones, I'll admit. Do you use, right, do you use grandiose on posteriors or anteriors or both? Posteriors. I will come on to occasions, you can use it on anteriors as well. It's a nano hybrid, you can use it on both. Next presentation, when I really get into much more of my MID, I'm going to be talking about layering of composites and using enamel and dentine systems and what's involved with those. And I encourage you to come back to listen to that and what I have to say about how to get those right. Somebody's asked me about level 2. Level 2, okay, is where you're doing I'll come back to that, and it is where I'm doing sandblasting, or you are level 2 is where you are taking minimal amounts of tooth away for sharp edges. You're using perhaps a bit of preparation on your veneers, and I'm going to talk a lot more about the U veneers next time and about how to do those, which I really love in MID because they are easily repairable, replace compared to porcelain, and I encourage you to listen to those. And so that's level 2. The next question. Thank you, President. Did you mean, it says, thank you, President. Did you mean we have to mix 2 different bonds to achieve a better bonding? Yes. I don't do it. Okay, I use a 1-bond system, time's money. But being honest, if you go into some of the more conventional bonds systems like Rely-X or some of Bisco's, you've got so many bottles and they are brilliant. And I would say to anybody, use them, but you've got to charge more because they take more time. But they probably give you a better bond. And you know, now there's even extra bonding steps for metal, and you know, people are really into metal bonding, and Bisco produce ZX and for using with metals which contains MDP, monomer dihydrogen phosphate, and things like that. And people ban these words around, but how many of us actually understand the chemistry? I don't. But you know, for zirconia as well, they'll say, I use them for zirconia. It improves your bond strength. They're making these bonds to sell to you, and you're buying them at fortunes. And do they really improve? I don't know. Here we are. Isn't there anecdotal evidence? Yes, we do rely on anecdotal evidence, and you know, we all do it. Why? So we should take all the research with a pinch of salt. Isn't the whole point to uncover the truths and falsehoods which may have hidden by the clinician's stubbornness? You're right. You know, you'll listen to people, and we all know there are people on there. And I work with Vocola. I'm under nobody's payroll. I just like their products and I read them, but I use other manufacturers. I work with SDI. I've worked with 3M, written for all these companies. And so I think they're all, let's face it, when you go to the high end, these companies are all good. They all sell products that work. When you go to the other end, own brands and the like, then do they work? Well, I'm not sure. Some of them may be as good, but I don't know what's the science and what's gone into these products. And even if I did, would I be able to sit here and tell you they're all fantastic? What I can say is, you mentioned about anecdotal evidence. I mean, I talk about things about how long does something last? I've been in practice since where I am now, since 1989. And except for my family who I could say some of those restorations go before that date, I've got cases, yeah. I've got cases that failed after 12 months, 18 months. I've got cases that have lasted for 20, 30 years. So, you know, that's still in a way anecdotal. What is the best treatment for the white patch on the tooth? Well, Icon is great. I don't think there is a best treatment, but it's minimally invasive. So use Icon. If it works, fantastic. You'll know that your lesion wouldn't have gone that deep. Regardless of what you do, if it works, you've got to use it because it's minimally invasive. You're doing less, you're just putting some chemicals on the tooth, you've got a permanent result and it lasts. That's great. But if you don't get you get a suboptimal result, and I mentioned before about a paper I wrote looking at it from the patient's point of view. The patient thinks it's suboptimal. Even if you think that's a great result, then do it. Please do it from what the patient wants. And then if they don't like it, begin at the beginning. Air abrasion, we're going to talk about that in a lot more depth next time. Using air abrasion, take it away, and then etch and bond a composite. You're starting with the least damaging. And that's why I say money, because we're all in business, unless you perhaps aren't have that constraint upon you in working, let's say, in community or hospital service. But, for in practice, you've got to build that into your model that if I've charged them or charging them a couple of £100 for using Icon, I don't forget the price of kit, 30, 40 quid from DMG. And again, available at many of the manufacturers that you would know, Shine, Dental Directory, whoever you use, right? Buy your kit and try it. I don't even mind saying the real reason for using stopping caries, what it was introduced for, they have one for a special kit for using interdentally. So difficult to use. Good if you could do it. I don't use it, and I don't think actually the patient category I'm treating, certainly not on the NHS, could you afford to use that as a preventative measure. But certainly I'll use an Icon for those patients where it's stained white spots. Doesn't really work as well for brown spots, let me absolutely say that, but certainly for white spots. It's really white spots, whatever they are. Yes, they work quite well with where it's caries, white spots. But sometimes you don't really know. Could it be a bit of fluorosis? Could it be one of those congenital defects, that occur, in around the birth or whatever during mineralization? You don't know. All I can tell you is stop thinking about so much about the etiology, but thinking how deep they are and how thick they are. And if they do go through, Icon's a waste of time. If they're really deep, Icon works very poorly. But if they're actually quite superficial, then it can work really well. And so, yes, it works particularly well for white spot lesions due to caries. Any good advice for final year dental student? The main point I would say to any final year dental student is two things. One, Paul Tipton, to me, is a great teacher, a great motivator. And I don't say that. And I want to tell everybody, I am doing this lecture for free for somebody I respect. I've listened to Paul. I've attended lectures years ago. And some of the things I do today are due to Paul Tipton. And I always think of number one is 2 3s holding a 6-unit bridge. And if you attend Paul, and I used to go 2 3 2 3 on the other side to hold a 6-unit bridge. So Paul says actually that you're better off actually from 2 3s than actually having 2 3 2 3, in longevity of bridge. And I kind of poo-pooed it at first, but it's true. And he altered my practice, I've got to say. So I learn from others and, listen. So, for a student, I would say to you, question everything, but learn from good teachers, people who have, are experienced, and attend postgraduate courses and listen, but always have that, as I showed you, how easy it is to get taken in. And when even people with professor titles, shouldn't say that to Paul, is got a professor title given to him, question everything, because often we'll find that things change, and over a period, even looking at this present COVID-19, you're fed information from all over, and people are coming up with theories all the time. And is it, even down to our masks, okay? Today, hey ho, DBG, I got some FFP3 masks this very morning. Do we need to wear them? I'm a bit of a geek. I've been really looking at these articles. I'm not actually sure we'll need to wear them. Go and look at fixthemask.com. Fixthemask.com. A Apple mechanical engineer with some other clinicians and everything involved found that with some rubber bands you can actually seal your normal surgical mask, and compared it to an N95, and they're coming up with some other contraptions. Do we need FFP3? How's it contracted, the virus? We don't even understand things like that, do we? You know, is it just the virus? Ah, well, the pore size is so much so, and it's therefore the virus is 0.12, it'll go through. Active virus, will it go through? Or is the virus, as possible thought now, is it coming through in liquid droplets? This is all evidence-based, or is it evidence-based? And people are just postulating theories. But I'm not yet convinced. When we go back, well, bits will change, but does it really matter? I think why surgical masks haven't been applicable is because they leak like crazy. But if you can actually put them onto the skin, and one of the things early on I questioned is, how do you do that? Well, tip of the day, I've got no evidence base for it. What I do know is about the SARS virus, and a lot of the research done on the SARS virus goes back to evidence-based research in 2012 about what kills the virus. And I'm telling you here, tip of the day, Corsadil gel. It contains chlorhexidine, not the highest alcohol content. And do you know what I'm doing when I'm going into the supermarket? Using Vicks, there's a Vicks First Defense. It contains, and way before the whole present coronavirus, it kills some of the coronaviruses. So I'll stick that up. Corsadil gel blobbed beneath my nose, so sniffed up like that. And well, go and listen to one of the, I think, the gods of dental research as we know it, Dominic Ahuli, who will tell you that they think that the ciliated cells and the goblet cells, maybe the H receptors in that, will take up the virus. Therefore, if you've got them covered physically with a load of Corsadil gel, and that it's got chlorhexidine and alcohol, isopropyl alcohol in it, and it'll kill virus, then maybe that, plus your mask, and I seal it with the gel around the sides, not wetting it, but sealing it around the side. Maybe should be using things like that. And then using surgical masks, which do stop droplet infection, and therefore maybe protectors. Do we know? Absolutely not. Hearsay. Don't take this as granted that I know. I'm just doing things off the hoof that many of you are doing. And I know I'm digressing from it, but to perform minimally invasive dentistry, we need to stay alive. And are you going to be able to get these masks, enough of them? Never mind the waterproofs. I don't know. But can we practice dentistry forevermore with an FFP3 mask? Categorically no. The inflammation and pain that these things produce, never mind all the pathogens that are on your skin inhaling them. I haven't a clue. I'm just like you. I haven't a clue. But I do worry about these things. And I think that we have to go back to a normal surgical mask or variant of it, but we can't wear these basically suction cups on our face forevermore. Never mind how we're going to communicate. Next question, how can you tell the white spot lesion clinically? You can't. You may get an idea by the color. If it's really light, you know, you might be able to tell, but if they are thick white, always be questioning, okay? Can ICON be used on children? Yes, you can. You can use it on children. Like that, the case I showed was a 13-year-old boy, okay? And you can use ICON. Can I just get this clear now? And even some of the gods of bleaching have talked to you about, well, you can use it for psychological reasons. Yeah, you can bleach. And I've heard that said in a lecture of somebody who lectures on whitening in one of the goddesses of bleaching, Linda Greenwald. That's her opinion. And I don't doubt that she thinks it's safe, and I've no reason to doubt her on that. The GDC say you can't under 18. So if you're going to do it, don't start saying, well, psychologically, and they often talk about whitening before icon, good idea. But psychologically, if you're going to do that, then get past the book, get a doctor, psychiatrist, psychologist. So if ever there was a reason and it got into something, I can see this, the patient not paying the bill, you sending out the letter, asking for the bill, threatening them, they then counter sue, you can't do it. And next minute you're in front of the GDC trying to defend yourself. And I don't think worry about it too much, but you've got to, the regulator is king and opinion is great. It's not the teacher who's going to be in front of the GDC, it would be you. So my advice is, if you're going to do it, get the backup. My patient really was psychologically affected. I didn't get the backup. There I am, telling you how it was, because I didn't need to. I'm using Icon. If I'd have bleached, perhaps now I would say for the bleaching I would, but Icon, isn't it crazy? H2O2, you can't use on a kid, but I can use hydrochloric acid on them. It's madness. Never mind the EU directives. In a compromised tooth structure, endo, upper right 5, would you prefer a crown or onlay? We always will go minimally invasive. There's your answer. So you've got to always judge things that, you know, some people, when I did dental school, this is, I kid you not, if it was root filled, cut it off. And so Paul was the same, cut it off at the gingival level. Now, I'm telling you, if you've got a good ferrule and a glass fiber post, ferrule of 2-3 millimeters, you don't have to crown. It won't break. And I'll say that, your post, a good ferrule and your teeth don't break. You may want to crown it for other reasons, appearance, but with a good ferrule and no cracks in as you view it on the tooth structure, a lot of the time you don't need to crown, but we're conditioned to do so. And often they're so discolored and everything, and there's massive tooth destruction, you might very well do it. But often, you know, I won't necessarily crown. So there's no answer to that, but I think except be minimally invasive and always think if something is going to fail, I've got to be able to restore it afterwards. So always be thinking in your head, minimally invasive first. I can always do the crown later. And some of you will say to me, yeah, but if it breaks with a root fracture, I might end up extracting it. Of course there is. There's always a counterbalance. And so sometimes I will go on and say, but if you're protecting the occlusal structure, and I'm not your expert, Paul Tipton's your expert on that, and as I say, I've learned so much from Paul, is protect if you've protected those cusps, yeah, certainly with posterior restorations, heavy occlusions and everything, I'm going to put a full coverage restoration, and I am born. I don't care, zirconia, bonded tooth color structure, there is nothing better to me than gold. Gold will last a lifetime, but not a lot of patients will accept it. But a gold coverage, onlay, 3/4 crown, they're decades. And many of my generation will tell you that. For dentistry and COVID, post the crisis, yeah, very difficult. Coronavirus and COVID-19 dentistry group, I think it is. My email is jeremycooper@jeremycooper.co.uk. So jeremycooper@jeremycooper.co.uk. I can check the exact name, but I think it's coronavirus and COVID-19 dentistry. I'm sure it'll come up on Facebook. That's great. And, you know, people like Dominic Hooley, he's a GDP, a guy into implants, but he's even more of a geek, I dare say, than I am. But I'm looking at so many articles. But even when I'm looking at masks, and I went into them at incredible depth, one mask I've been looking at research studies from South Korea to Germany, translated into English. What do I know? But one of them was 4 patients looking at it coughing. And even, you know, this, how long's the virus going to? I've written How long does the virus take to settle? You're advised by the NHS England and Scotland to wait 1 hour before going into the room. It's not viable to, never mind, wait an hour and then beginning cross-infection control, which would involve cleaning your skirting board, your walls, for the virus. Interesting, isn't it? And I know I'm keeping you waiting, and I hope some of you are enjoying this before I take my last question. They'll tell you that, and that's what you've got to follow. The research was done, and I've written to NHS England. I haven't had a reply to any of the questions I sent. That just shows you. Giving them evidence-based research, reputable organizations who have questioned this whole thing. The research was done in New Hampshire in the United States. They on COVID-19, not on other viruses, but actually comparing COVID-19 and SARS virus. And they did it in a lab, and everything's been porn scorn. It takes 3 hours for that virus to settle. That's 3 hours. And I'm going to say to you, 3 hours for a virus to settle, that's not viable. 2 patients a day, an hour for cleaning, 30 minutes. So how can you do it? WHO have looked at that research and said, well, it's done, it's high speed, it's done in a laboratory, it's not relevant for dentistry, and certainly for coughing, it may not be. Well, we're using high speed equipment, maybe more relevant, I don't know, for an aerator being used in the surgery. High speed, you could say your 3-in-1's more like a cough. I don't know, but certainly with an aerator. Therefore, I would love to ask those people, and I'm going to say, I think Sarah Hurley's been very unfairly treated, but maybe she's been up against the wall with perhaps a reaction to a colleague in her webinar. But does it wait 3 hours? Would she wait if she had her mother or nearest and dearest, and there's my self-test or my mother test coming into operation, put hers in and just wait an hour before you, after treating a known COVID-19 patient in that surgery, in one of these urgent dental centres that took 4 weeks plus in Manchester to settle? I actually don't know. And I would prefer to wait 3 hours if I'd had a known COVID-19, and I dare say many, many others would, but you're being told 1 hour in these urgent dental centres. Nobody's done, other than that one study that I know of, that 3 hours is the time you should be waiting in the absence of other research, in my view. But that's just my view. It's not evidence-based. They're telling you to wait 1 hour, certainly better than not waiting at all, but should we be waiting other times? So there's evidence-based. And I know I've gone off there. Thanks for the lecture. I'm just going, interesting thoughts. Right, another question actually, aerosols from further down the respiratory tract. Yes, actually there has been some research. SARS actually does do receptors down the H receptors. And I read an article, say in Germany, that actually talks about it hitting right down the tract on the H receptors down the tract. So that has been proven that it does affect down the tract as well. Again, I'm just reading the same as you. I hope you've enjoyed the presentation and will attend in due course part 2. There'll be a lot more clinical stuff and new things for you next time, but it was really, my aim today was to try and entertain a little bit and whet your appetite a bit more, and particularly get you questioning everything. And I know what you may not like my approach by saying, I don't know, because I don't, but actually, hopefully you'll do that. Part 2 is in a few days, and you will be told by Paul Tipton's organisation when part 2 is coming up. And I hope you've enjoyed it. And I go back to it. I'm a GDP, just the same as any of you listening in. I'm definitely going to say older. Wiser, I'm not so sure. I've made all the mistakes that every single one of you listening have made. And hopefully just passing on what I've picked up from other people, my own experience, and someone meant that, anecdotal, okay? And things I've learned from the greats, and I'll put Paul up there. You know, he's taught me more than anybody. And so somebody asked early on, a younger member of dentistry, what should I do? Go on approved courses by people like Paul. And I know a colleague of mine and an experienced colleague of mine in her 40s has enrolled on Paul Tipton's courses and had her whole dentistry altered by what he does. And he is great, you know, education well spent, you know, and people like him. And there are others too, I know in the UK, who have courses, as well as the Royal Colleges and courses by them. So go on any of these, but carry on learning. I never, ever stop. And thank you. And at that point, I think it's time to end the meeting. I've gone on far too long, taken up too much of your time. I look forward to welcoming you all again soon. Thank you. Okay, with no more questions, cheerio.